Welcome everyone. Be it good morning, good afternoon, good evening, depending where in the world you're taking this in. We're now moving to the session looking at ethics and people's rights. This is a key issue when we're dealing with any issue of public health. The whole area of tobacco, an area I've been involved with from a public health perspective for about 40 years, has been quite confused on this topic. And I think this section hopefully will help us address some of that. And we've got a terrific lineup of speakers, starting with Dr. Charles Gardner, who's a PhD in neurobiology and has worked in various aspects of this issue, but is now the head of the International Network of Nicotine Consumer Organizations. So a group that's representing the consumers themselves, a voice that's often just not heard in policy discussions on tobacco and nicotine. And then we'll have Dr. Stanimir Hasardzhiev from Bulgaria, who's the head of the Bulgarian National Patients Organization, someone who's been very involved throughout the European Union on issues of empowering the patient community. Again, what are the rights of the consumers? And now, if we can move to Dr. Charles Gardner, if Charles, you're available to look at this from a consumer standpoint.
Yes, thank you. And that was a great talk. Happy to be here. And our focus is on ethics and human rights. It's very relevant to my concerns today. I'm the executive director of INCO, and that's a nonprofit organization. We have 35 member organizations all around the world. And our purpose is to support the rights of the 98 million adults worldwide who use safer nicotine in order to avoid toxic forms of tobacco. Coincidentally, I used to teach healthcare ethics at a historically Black university in the United States called Howard University. And we were teaching medical students and nursing students, and we focused on 5 basic moral principles. The first 2 are beneficence and non-maleficence. And so that's do good if you're a doctor or a nurse. And non-maleficence is do no harm. That's a common phrase in English. And then there's autonomy. So this is the third one. Autonomy is truth-telling. Autonomy is informed consent and informed choice. Very important. And then there's justice, which is treating everyone equally, whatever their gender, whatever their ethnic background. And so justice is important. And finally, utility. Now, utility comes from John Stuart Mill. It's the greatest good for the greatest number. What strikes me when I look at the tobacco control field now is it takes a population-based approach to interventions. So this is very much a utilitarian approach. And if you just open an introductory textbook for medical students on healthcare ethics, you will find it full of case studies that are about the conflict between autonomy, which is informed consent and truth-telling, and utility, the greatest good for the greatest number. And my general sense, and this is a very broad brush comment, is that tobacco control policies are often blind to the importance of autonomy. And here, as I'm strongly supporting what Lynn says, which is that smokers and users of safer nicotine and the general public need to be, and policymakers need to be informed. And the evidence shows and the surveys shows they're profoundly misinformed now, unfortunately, about nicotine and about the relative risks of different nicotine products. The main thing I want to focus on is something I've really been thinking a lot about now, especially because I've done surveys of advocates in my community, is the issue of mental health issues. But before I get there, to paint the bigger picture, let me just focus on the high-income countries where we have succeeded in getting smoking rates down to relatively low levels. The pattern of smoking in these high-income countries, especially like the United States or the United Kingdom, where smoking is now down to 14 or 15% of adults, is very, very different from the pattern you find in many other countries, low and middle income countries. Just to take one example, China, more than 50% of men smoke in China, 30% of doctors smoke, and there are smoking lounges in the hospitals for doctors and nurses still in China. So the pattern there is kind of like it was in Europe and the United States and the UK, 40 years ago, where it's the general population is smoking. Once you get down to 14, 15%, I'm going to argue that the people who are still smoking are by definition those least able or least willing to quit. And when we look at who those people are, we can just turn in the United States to CDC data. American adults living with mental health problems smoke 40% of all of the cigarettes in the country. And but it's not just people with mental health problems. So the smoking is concentrated now in our most vulnerable communities. Obviously, this raises social justice issues and rights issues. Those vulnerable communities are where the smoking rates are highest are low-income peoples or people in the LGBTQ community or the indigenous population or people who are homeless or people who are using illicit drugs. And then the big one, people living with adults living with mental health conditions. So to take and focus on that in the category which some people now call neurodiversity issues, adults living with ADHD or autism, 40% of them smoke. And the general population in the US is 14%. Adults living with bipolar disorder, it's 60% smoke. Adults living with schizophrenia, it's 71%. And so, and the numbers are very similar for people who use opioids or people who, so we need to understand that the pattern of the population that are using cigarettes or combustible tobacco is very, very concentrated now in these communities who are by definition vulnerable, already stigmatized, and then because they smoke, they're doubly stigmatized. And if they are to switch to a safer nicotine product, unfortunately, public health wants them to be stigmatized for that these days. And so that's my concern now, because I now have come to understand that a very substantial percentage of people in the advocacy community for safer nicotine are people living with neurodiversity issues. And so we have started to talk about this a great deal. This is your superpower, right? This is your ability to focus and concentrate. But the prevailing theory in the literature for these very high rates of smoking among people with many mental health problems is that they're self-medicating, right? So the impact of nicotine is not to intoxicate. It is just a mild increase in your focus, attention, and memory, and then paradoxically, a mild reduction in stress and anxiety, right? So if you're in any of these populations, you are under stress and you want to reduce your anxiety and stress. And if you are living with ADHD, you want to increase your focus and attention. None of this should surprise anyone, but nicotine is obviously so demonized that I would suggest that as with psilocybin and psychedelic therapy, decades of research have been neglected looking at the health benefits. Now, there are some studies using nicotine patches, transdermal nicotine, for adults living with depression, for example. They're quite positive. And so there is some missing research, but on the other hand, there's a lot of research. It's just scattered, and I would point out that the U.S. National Academies of Sciences, Engineering, and Medicine conducted a thorough analysis of the benefits and harms of cannabis and cannabinoids, and the report is published in 2017. It's quite stunning that there is no comparable review of all of the science on nicotine's dependence-forming characteristics, its health benefits, and its potential risks at the same time, because obviously, as Lynn points out, smoking is killing a lot of people every year. It's a more than COVID-19. So let me start to wind down and simply say that the fact that smoking in high-income countries is now concentrated in our most vulnerable communities, and they are being denied in many countries access to safer nicotine alternatives, raises tremendous human rights and social justice questions, at least. And it's an issue where we should be getting more healthcare ethicists, bioethicists, to start thinking about these things, because they approach these problems with a different set of tools, mental tools. So that's, let me leave it at that. And I just look forward to further conversation.
Fantastic. Thank you very much, Charles. I mean, we've had some very key points raised from the first two presentations. I mean, I'm reminded as I listened to Lynn of one of the first books recommended to me when I started my career in this area, which is by Robert Sweanor, called "Don't Blame the People," saying people can only make as good a decision as the information available to them allows. And it is simply not on to give people inadequate information to make an informed decision, or in fact mislead them, and then hold them responsible for having made a bad decision. And in listening to Charles, I think we can take that farther to say it is also not on to push people to make changes that in effect their biology doesn't make viable for them, or makes incredibly difficult for them, because we're again failing to reach people where they are. We are failing to empower people. The basic tenet in public health of nothing about us without us. You know, involve the people whose lives you're trying to save. Give them adequate information. Give them the information they need to be empowered, and understand where they're coming from. What are their lived experiences? So, I mean, it's extraordinary just how far a lot of people in tobacco control have got from what we would see as mainstream public health. And now, to conclude the presentations, I'd ask for Stanimir to talk about this from his standpoint as a doctor, a patient advocate who deals with these sorts of issues of how do we ethically address the need for consumers to have information and to be able to be empowered to make better decisions about their own health. Stanimir, over to you.
Thank you very much. Thank you for the invitation and the very interesting presentations prior to me. I just have some thoughts on what I heard already from the previous two speakers. First of all, I was thinking on the two countries that you were quoting, United States and UK. Even though the number of smokers and the percentage of smokers is smaller, I can see huge difference in the motive and the drivers behind that between the two countries. And while in the United States it's more of a cultural and trendy issue, where I personally have felt always going there afraid of not being caught somewhere with a cigarette, because everybody would look at you as being a criminal on the street. I think the difference with UK and the Brits is that their government about 15 years ago started implementing and encouraging different programs for harm reduction. And I wouldn't say that it's so much the cultural component through the Brits, rather than the government's efforts to encourage some replacement of the more harmful product with some less harmful products. This is first. Second, on the higher income countries, I I think that there might be such relevance that high-income countries have a lower number of smokers, but this is not kind of a rule that is valid universally, and we can see countries and nations that traditionally simply smoke. The French, the Spanish, the Italians, for example, these I wouldn't say are the poorest countries in the world, but still they have huge issue with number of smokers. And this is actually just to confirm your words at the end, that it's different from country to country. We cannot really generalize about people, and people are people, and they have common way of thinking, despite the cultures, despite the realities, despite the economic situation. Still, people are people, and they very often are following what the societies do. Unfortunately, I live in a country which is the smallest, not the smallest, but one of the youngest and the poorest EU member state, with the highest number of smokers, despite all efforts of our government, despite all bans, despite all increases of taxation and axes and whatever. The Bulgarians simply want to smoke, and they do smoke. And what's more, they enjoy that, and you're a minority if you don't smoke here. You can really be discriminated, and it's more or less a cultural thing. Not that I like it, but this is the environment I've been living in. And this is where I've been growing up, and my friends, and and now my daughter or son, or the people and the kids, they live in exactly the same environment. We still have these huge percentages. For the last 10 years, we don't have even 1% drop in the number of smokers. And we have introduced all the bans and everything that needs to be done. So what are we doing in such situation? And do these people have a right, or they're guilty because they're smoking and they still have the highest mortality rate, etc., etc.? How about those who have chronic diseases, for example? And people with chronic diseases are even more vulnerable to the harm that smoking can do to them. So having a chronic condition, I'm not talking only on chronic condition of your lungs, but you can have diabetes, you can have high blood pressure, or any other risk factor for the high mortality that we see in Europe, combined with smoking, is worsening the situation for the main disease of these people. And we live in an era where we have enough data, and more is coming, that there should be another way to work with those people, to engage with them, to understand why they're smoking and why they don't want to quit smoke, or they can't, or simply they live in such environment where it's absolutely impossible for many of them to stop smoking. So instead of waiting for this generation to die or to change, we can do something more. And obviously now we have enough data to show us that there are other ways. And the example from UK is a fantastic one, just because this, from my understanding, is the only clear case when we have proper programs where the government stays behind those programs for harm reduction, besides some of the examples we have from the Scandinavian countries, etc. But there we have dedicated government with concrete steps program that's followed. So if this is the way forward, why don't we do it with other governments and in other places? And I've always asked this question: do the smokers have the right to know what are the alternatives? Do they have the right to know what the science says, or what are the results that we are reading every day in the scientific literature? But then when we try to talk openly about that, especially in the scientific world, it's discrimination to the scientists as well. And I'm sure you can confirm this, that many of us have been discriminated if we only dare to say something in favor of less harmful products or alternatives for patients. But I think that people, and in particular patients, the population that I'm taking care for in the last years, having alternative could be a big change for them, chance to reverse their in any case bad future and destiny time. It's a chance really for those people to start controlling the things again back in their hands, rather than simply living day after day and waiting for the inevitable to happen someday. And I think that these people have the right to know about what the science is finding out now. I will finish my intervention for the moment with something that happened to me not long ago in a conversation with some representatives of WHO. Again, on the topic, we've been discussing many topics, and they loved me so much until the moment when they asked me the question, do you have something to do with tobacco and this bad community there? And I said, yes, why not? They were so surprised that the patient leader in Bulgaria and the leader of one of the biggest healthcare organizations in Europe, which is the Access Partnership in Brussels, was so open to them and said, yes, we're talking about these questions. We're talking about that because our patients have this problem. And despite how much you can deny that, or you can refuse to have this conversation, we have to have it because patients do have those problems and somebody has to address it. You cannot simply leave behind, because we all know the motto, nobody left behind of WHO, but you cannot simply leave behind so many people who have tried and have on top of that a chronic disease, but still cannot quit smoking, and a person who is fighting with some major disease like cancer or something else, and you're telling him you are an idiot because you cannot stop smoking at that moment as well, and not showing to this person the alternative or what the science has provided to us up to now. And yet their only argument is that we don't have long-term data. And then my answer is, I also don't have 20 years ahead to wait for the long-term data in order to understand that I have been right here and right now. And this is a right to everyone. I'm healthy, luckily, but many people don't have this time to wait for the long-term data. They have the right to know the data as it is today, and they have the right to take their choice and their decision right here, right now, of course, together with their doctors, together with the experts, together with everyone who's taking care for them, based on evidences and knowledge from a personal point of view. Thank you.
Thank you very much, Stanimir. I'm reminded of the line that what really distinguishes a good doctor from many others is, do they truly care about their patients? And I can see that in you, and that's what's led to your interest in patients' rights, and to be able to provide them with the information, with the alternatives, with the ability to empower them to take better care of their health. So I really appreciate your contribution.